Thank you, Susan. And I have the privilege of hosting this session on innovation today on behalf of Nikki Pye, who has arranged for this session for us. And our speaker is Dr. Nora Engel. Dr. Engel is an associate professor of global health at Maastricht University in the Netherlands. She's in the Department of Health, Ethics and Society, and she's also a member of the Interfaculty Maastricht Center for Global Health Research and Training. She's a social scientist, and she has a particular interest in how new technologies and interventions for global health challenges can be envisioned and developed and implemented. And then she evaluates their use to make sense of how these innovative, dynamic interventions are impacting theoretically. She's done extensive qualitative field work in India and South Africa, as well as in the global health policy arena, among others on innovations in TB control and policy, challenges to point-of-care testing, the evaluation of mobile health solutions and innovations, and point-of-care diagnostics for TB and HIV. She's also an associate member of our International TB Center here at McGill. So I would invite you to leave your cameras on if you are so inclined. It's always nice for our speaker to be able to see some faces instead of just a sea of black squares. And I will turn things over to Dr. Engel. Welcome.
To find the unmute button. Thank you so much, Susan, for the kind introduction, and thank you so much for inviting me to speak to you today. I hope you can all hear me okay. Yeah. So I will be talking about how to use qualitative research to study global health technology and innovation dynamics. And before I start off, I just wanted to make sure that, because I don't know you, I just wanted to make sure that you have kind of a rudimentary or basic understanding of what we're talking about when we talk about qualitative research. Is that clear, or do I need to say something about it? That's clear. Okay, perfect. So let me see. Slide's not moving. That sometimes happens. There you go. So I think we would probably all agree that the global health community in general puts a lot of hope into science, technology, and innovation for solving global health challenges. For instance, point-of-care diagnostics, those are devices that promise to bring laboratory-based precision to settings that have limited laboratory infrastructure, or where accessing laboratory result just takes too long, or is inconvenient, or is just not a possibility. And these devices then promise that healthcare workers can make better informed treatment decisions, put patients on the right treatment, cut diagnostic delay, and therefore increase or improve overall health. And we also know, I guess, and we would all agree that that doesn't always happen this way. So, and that is because it is very challenging to innovate and make technologies and any other interventions work in global health settings, because we're talking about very different contexts, and also often contexts that are in some way or the other constrained in resources. And it doesn't always have to end up as drastically as on these medical device cemeteries. But we do know, for instance, about rapid tests, that the promises are not automatically met when we have rapid, simple, and low-cost tests available at clinics. Sociological or anthropological research has shown, for instance, that malaria rapids are not necessarily applied rapidly, or they're misused. HIV rapids similarly not always used to make treatment decisions. And we also know, for instance, for the TB gene expert device, that in some settings it required additional human resources beyond what was available in clinics. And it did not necessarily cut diagnostic delay compared to what was already available in some of these settings, because patients were still asked to come back in a day or two. And then the implications, if these promises are not met, are of course quite dramatic, if you want to say so. We then do not have cuts in diagnostic delays. Patients have a chance to develop advanced stages of diseases or more complicated diseases and continue to transmit to others if it's infectious diseases. And they might get frustrated and not return to your clinic. And we have then invested into technologies, a lot of funding and resources that could have maybe been invested better elsewhere. So why, what is going on here? Or what could we, how could we conceptualize this to somehow improve it? Any technology, in order to function, no matter how simple it is, requires work by users to make it work. And that type of work is often not very well recognized in the global health community by funders or some of the designers. For a point of care diagnostic, for instance, the work that is involved requires a patient to seek care. It requires somebody to order a test, then conduct the test, act on the result, first read the result, then act on the result, and finally make a management decision. And we know that in all of these steps, things can go wrong. And all of these steps, however small they are, involve some form of work by different types of users. And they might use the technology differently than designers anticipated. They might, for instance, decide not to use the diagnostic result to inform their treatment decision, or they might not agree with the waiting time that is on the device. Or they might just fit it into their workflow in a way that they rather batch tests and then tell patients to come back the next day. All of these things we have documented with the type of work I'm doing. And so the users use this technology differently than the designers anticipated. But the users are, of course, also constrained by the technology as such, what the designers have decided, what's in the device and what sample you have to use, or what equipment is necessary to maintain it, etc. And so there seems to be this kind of making technologies and interventions really fit the users, and to have more kind of communication, coordination, collaboration between use and design, I think is crucial. And we can use qualitative research to help us do some of this work. For instance, we can use qualitative methods for medical device design and implementation, where we actually inform product design. So for instance, by running studies on user needs, so really using ethnography or interviews or focus groups to really understand what the problem is, how a diagnostic ecosystem functions. You could also add it onto trials where you test new devices or new global health innovations and study how trialists experience the innovation. Or you can add it into or study devices once they're being implemented to answer questions about technology and use. And I'll talk about two examples today, and the first one probably can be located in that type of group or type of qualitative research. You can also do qualitative research of medical device design and implementation. And there you're essentially taking a step back and you're studying the entire innovation process. So how do those who innovate in global health actually go about doing so, from design to R&D, evaluation to then finally implementation and maintenance. And a discipline that lends itself very well to do so is science and technology studies. That's essentially, a kind of disciplinary lens that's used by anthropologists, historians, sociologists, but also former engineers or microbiologists who use social science insights. And these scholars, and I just pasted a few book covers here just because they're nicer to look at. There's different types of studies. These scholars have done, for instance, studied controversies in biomedicine, or they looked at how the MRI scan has been developed across different countries, or the challenges around standardizing clinical guidelines, or how innovation in TB control unfolds, or global health research partnerships work for HIV control. And what these studies have in common is that they show that medical technologies do not evolve in a vacuum. business interests, scientific trends, regulatory environments, social, institutional, political processes all shape how technologies look like, the decisions that are being made in the design steps, evaluation, etc. And then also how they are used. And at the same time, of course, the things that we use, the material, the techniques, the technologies, the artifacts, they also shape human action. So this basic interaction between science, between technology and society, this mutual shaping is really at the core of this, the core insight, I guess, from which these studies work, or these particular STS approaches work. And this slide says the same thing, just in text. The implications of this are that biomedical technologies are never autonomous entities. They're not separate from society, neither in their development nor in their implementation. They're always enmeshed with medical, social, and political aspects, and that has real world consequences. So if we take this starting point that science, technology, and society mutually shape each other, and that global health puts a lot of emphasis on the role for science and technology to solve global health challenges, in my opinion, then we need to really understand much better how global health innovations are used and how we go about governing and practicing innovation, actually. So reflect and study much more how innovation processes unfold in global health. And I provide two examples from my past work that speak a little bit to these two aims. The first, and please just maybe I just take a second here if anybody has a question. Okay, just interrupt me. So I won't have much time to go into these examples a lot, but I'll post some references to published material, and if anybody wants to engage further, I'm happy to answer emails afterwards. So this is actually a research project that I did together with Nikki and Madhu Pai. It was the first time where we really worked together intensively. And what we wanted to do here was to identify the biggest barriers to successful implementation of point-of-care testing in different points in the healthcare system in South Africa and India. We did a lot of semi-structured interviews and focus group discussions with various healthcare providers and also test manufacturers and lab technicians. And the kind of underlying framework that we used to study barriers to point of care testing was not necessarily focused on a specific test or product. Instead, we had defined point of care testing as a process. So a successful point of care testing in our definition involved a patient accessing the healthcare system and leaving that encounter with an actionable management decision based on a diagnostic test result. And as long as that sort of test and treat cycle was completed within 1 day, we would call it successful point of care testing. So that they also did more justice to this basic insight that I just described, that technologies, diagnostic practices in the health system are inseparable and they're mutually interacting. And then what we essentially did is in both countries, we went to these 5 settings, and looked at how people were diagnosing the major infectious diseases that they were dealing with in these places. So self-testing at home, testing in the communities by community health workers in clinics, peripheral labs, and in hospital wards outside the central lab. And we wanted to understand what were the difficulties people were facing with making diagnosing and diagnostics work, what technologies were they using, and were they able to complete these test and treat cycles. And this type of mapping and talking with people in great detail about their diagnostic processes generated an enormous amount of rich data. And we've published this. It was difficult to publish because it was going across settings. across actors and across diseases. And the reviewers didn't like this, and they wanted us to focus on, one or the other. But I'm happy we got it through these critiques, and were able to show the like how things are working in combination. And I just want to highlight one result. So in India, we showed that point of care testing in the way we had defined it hardly occurred in any of the 5 settings. And that had to do with that rapid tests were not translated into rapid treatment decisions because they were largely done in laboratories. And there just the turnaround times were too long. Patients were just asked to come back the next day, as has happened always. And in settings where the turnaround times were shorter, these rapid tests were usually not available, or they were too costly. And then in the private sector, to which a lot of patients in India turn, the GPs, they found alternative ways to ensure that their patients could visit a laboratory, a private laboratory next door or down the street, and return the same day with the result. And they sort of reopened their practice in the evening. So they were coordinating the opening hours with these other labs. But that sort of allowed a point of care testing cycle to be completed, but there were also kickbacks involved, that these laboratories pay the providers for sending the patients. And so that's a form of corruption, of course. So that might incentivize malpractice in the sense that these providers might order tests because they're interesting in terms of the kickback that they get, instead of ordering the tests that are actually needed. But what I want to highlight here is this. We try to illustrate the main barriers that we found in this setting. This is for India. And essentially, we grouped the barriers into 3 sort of major themes of barriers to point of care testing. The first one was infrastructure. So everybody was kind of constrained by either limited equipment and finances, or can you see my pointer? Or the HR shortage, high workload, and scarce testing material, and also the patients, of course. But also the other actually really striking sort of sets of barriers were the relationships between the different people. And so a lack of coordination, cooperation led to a lot of disruption in these point of care test and treat cycles, sorry. So a typical patient, seeks first care in the private sector, and these private providers have a tendency to keep costs low, at least in those neighborhoods that we did research on. And so they wouldn't ask for investigations on the first or second visit, but maybe on the third, and then send patients to these peripheral labs with whom they have these relationships that I had just described. And then at one point, if this setup is not successful or the patient doesn't get cured, at one point the patient will seek care in the public sector, especially TB patients. And here the issue, they might visit a medical doctor here in the clinic, but there's such a high workload often. And the laboratory technicians are often overworked, so that the clinician here has a very low incentive to order investigations. And if you see 100, 110, 100 patients a day, you only have a few minutes with each person. And so that discourages you to order investigations, especially if you know that the laboratory technician will ask the patient to come back in a day or 2, just because of the workload. And there was also a lack of cooperation, low accountability, and blaming between these actors here, which also reinforced a lot of breakdowns of this test and treat cycle. And there were a lot of options for patients to opt out. So these relationships, and there were other types of relationships also to hospitals, etc., they really meant that in combination with the infrastructure, people were adjusting their practices, and those practices then were largely favoring empirical treatment over investigation in both the private and the public sector. So private practitioners try to cut costs and avoid losing their patients, and therefore use empiric treatment, and public sector providers usually have low incentives to order investigations, just try to manage their high patient loads. And patients end up shopping around for diagnosis.
Nora,
So
maybe
when you
maybe I could jump in here with just a couple of questions that have come up in the chat. The first question from Sarah Ahmed is: are all users or patients or lab team members interviewed? And if not, how are you picking who's getting interviewed? And the second one comes from Teresa: is point of care testing acceptable to the medical personnel?
So the second question, I do the second question first. So in this study, remember how we had defined point of care testing? We were just trying to understand how are people currently diagnosing these diseases. And so we paid attention to the types of tests they used. And that's why we saw that when there were rapid tests, they were used mainly in labs. And it was always the lab technicians who did those and not the medical providers, for instance. And the GPs also had no interest in running any tests in their clinics. At most, a pregnancy test and a diabetes kind of sugar measuring devices, but only then if patients bring them themselves. So we weren't going in with asking, would you accept point of care testing? We were studying what they currently were doing. And from there, tried to understand what would a new point of care test have to look like in order to work in such a in such a context. And the first question was about how do you pick who you interview? That depends on the study, and there's feasibility constraints and or considerations and your question. With us, we were interested to speak to those people involved in these diagnostic processes in these 5 settings, and we had put, I think, a kind of a target for how many per setting, and so that involved trying to just understand the process and then talking to all the actors involved along the process. So yes, patients, lab technicians, clinic providers at clinics, some clinic managers, diagnostic manufacturers or suppliers, for instance. Yeah.
Thank you.
Okay, so with these type of qualitative research, you then end up with kind of illustrating the complexity of the practices that is going on in these, let's say, diagnostic ecosystems. So how do you, what do you conclude from this for people who want to develop new innovations or new diagnostic tests that work in these settings? So we came up with the following. Currently, there seem to be limits to what material and money and human resources new tests can rely on. So that's rather resource constrained, all of it. But also, often when we're talking about developing new point of care tests, we actually assume functioning relationships between these actors. However, we showed that that's not necessarily given. And also, I don't have time to go into this, but we had several examples where tests actually either harmed or supported the relationships between different actors. And so I think what it shows is that these barriers that we identified of infrastructure, relationships, and modified practices that favor empirical treatment, they don't act in isolation. These material aspects, the sociocultural relations between actors and their diagnostic practices are inseparably related. So how do you then take this type of complexity into account when designing new point of care testing programs or devices? And these are my preliminary answers. If you have better ones, I would be very interested to hear. But I think we need to do more studies of how diagnosing is practiced, or any type of practice where you want to innovate in, before, during, and after design and implementation. So really make it a part of the innovation process as such. And then we need to somehow find innovative ways to tackle jointly the relationships between providers and between patients and providers, infrastructure, and then adaptive strategies of dealing with constraints that people have. Somehow also really, I think there needs to be much more attention to the role and responsibility and work that we ask patients to do with innovations. And we need to develop research capacity that allows us to integrate these factors into ongoing innovation and design practices. Yes, so this was the first example. That was more of the kind of qualitative research for medical devices and or for global health technologies. And the second one that is more a sort of an STS study of innovation processes in diagnostics. And this was a project that I did after this, this barrier project. And here I was trying to understand how do those engaged with developing and implementing new point of care diagnostics for TB and HIV actually ensure that these techs work at point of care. So how does the innovation process function? And more specifically, how do the designers know the point of care and then know what they have to design so that it works at point of care? And it involved fieldwork both at the global level in combination with a more local fieldwork in Bangalore in India. And it was essentially interviews with those actors along the entire kind of value chain of diagnostic innovation. So designers, researchers, funders, diagnostic manufacturers, regulators, policymakers, end users. Yes. And some of it is published already. I pasted this here. So I was really interested in trying to understand how these developers and these manufacturers know the point of care and know their users. And what I found throughout these interviews was that the users of global health technologies and diagnostics, they are multiple and variable. So remember the work that goes into making a point of care diagnostic function. So you have different users, technicians, patients, clinic staff, lab managers, ministries of health, NGOs, regulators, funders. All of these people become users at one point in time. They do different things as users. Some of them supply a bodily sample or receive a result. Some order a test or act on its result. Others conduct a test or maintain a machine. Again, others evaluate safety and quality, oversee deployment, etc., or purchase these devices. And because in global health, we, are often hoping to achieve standardized products that work across different settings, we're dealing with very different countries, different laboratories, different types of clinics, different types of communities. So that makes variable and multiple users. And diagnostic companies traditionally they're used to customers that are hospital chains and not necessarily donors or governments or NGOs. And some of these new kind of customers, they also have not really dealt with diagnostic devices before. So they're kind of inexperienced and some understaffed customers also. This makes it rather complicated for these diagnostic developers. And I try to conceptualize their attempts of making their tests fit the point of care with the concept of alignment, illustrated here in this kind of figure. So here's the developer, and he or she is trying to figure out all the different elements of the intended use setting that are potentially important to know, and then kind of aligning it with what they want to develop. And these elements, could involve the epidemiology, patient profiles, how do these clinics look like, what's the equipment in laboratories, how temperature sensitive does this have to be, what are current guidelines, what's the market, what do physicians want, what do patients want, all these different considerations. And you have to somehow bring this in line with what you as a company, maybe a startup, have available in-house. So the kind of techniques that you're good at, the materials you have, the shareholder interests, the funding you have available. And that's not always easy because, keeping your shareholders interested on developing a tuberculosis diagnostic, that's absolutely not profitable, is difficult. And what makes this additionally complicated is that these users of these global health diagnostics are not only multiple and variable, but they also shift, and they're very hard to access. What I mean with this is that in these clinics, you often have very high staff turnover. So you have constantly new users. And also because we're talking about point of care devices that are sitting, in a clinic and not necessarily in a laboratory, you don't have a dedicated user. You might have a user that doesn't really care about your device. And one of the test developers put this very nicely here in this quote: "You're not dealing with a dedicated lab personnel, but nurses, doctors, etc. And they are dealing with patients, not only with tests." So this makes makes for a different challenge to develop a diagnostic in this particular setting. Plus, then the data on these users is really difficult to access or generate. There isn't much data about exactly how diagnostics are used and the diagnostic processes in these clinics that is easily available. And that data also changes with different aspects, and I put just some of them here. Even while I was doing interviews, the WHO changed, essentially suggested to drop CD4 counts and go for viral load. And that had a dramatic effect on the market, of course, for these diagnostic developers. Yeah, so these type of things. And you can't just walk into a clinic as an industry person of a TB control program and give your prototype to a few nurses and ask them to try it out. That doesn't work like that. And so those people who are successful in this space, they really find ways to engage these users, and it requires ongoing work, often over years, and ad hoc arrangements, substantive investment. It involves tinkering and being creative. And for many of these diagnostic companies, which are often startups, in Silicon Valley or wherever, they often require help to do this. And that's where what I call intermediaries come in. Those are donor groups or the global health technologies with the global NGOs with a focus on technology, but also working groups of WHO, MSF, or individual industry consultants. And they sort of mediate between the point of care and these developers. They help them to get to know the point of care. They make introductions. They help them also access the material. For instance, access to sputum. Like one of the diagnostic companies that I interviewed, they were based in Silicon Valley, and they had been working with sputum from a local sports club. But that's very different from the real thing that you want to use when you're developing a TB diagnostic. These intermediaries also publish market landscapes or target product profiles that define optimum and minimum requirement a new test should have. And this is very helpful to the diagnostic developers because it minimizes their risk. It helps them, it guides them on what they should be focusing on, what price range, etc. But at the same time, these intermediaries, they of course also act as gatekeepers. So with these target product profiles that I just showed here, if you have if you're developing a diagnostic and it doesn't fit into the TPP, and these TPPs have been published by WHO, it is very difficult to find support among the global donors or those groups in this space. Intermediaries also provide direct engineering advice. One of the test developers, they were working on a new TB test, and they were thinking of also engineering the Sputum Cup. So when you are testing for TB and you're asked to provide a sputum sample, you typically cuff into these little plastic cups, and they just have a simple lid. And then the laboratory technician or whoever does the test needs to open this again and take the sample out. And they wanted to engineer that and make it more biosafe. But then they told me, well, both WHO and FIND said that really you should try and stick to the current protocol where people are coughing into a plastic cup that's not been engineered. And it's a balance, because when we talk to users in clinics, they were saying they really hate dealing with sputum in an open cup. But WHO and FIND had said that these TB programs have already purchased millions of these cups. So it's easier, if you don't engineer these ones as well. So it shows that when you are trying to develop a new diagnostic and align it to the point of care, you're also aligning to global agendas and standards to access funding, samples, field sites, users, and key opinion leaders for feedback. And when you are aligning these different things, elements can conflict with each other. Should you go with what the user told you to make a biosafe sputum cup because people feel unsafe at work, or should you rather stick to what these global intermediaries suggest you to do, who might be co-funding your development? So there's politics, of course, also involved. And it is for developers also not always clear what the actual job is. Is the job diagnosing tuberculosis or diagnosing tuberculosis in a biosafe way? And so then the rightness of the tool keeps changing depending on who you ask and in which context you are. That can be confusing. So clearly there are more settings that matter than intended use when you're trying to align your diagnostic or make it work in global health. You're not only trying to align to the elements of the intended use settings, you're also trying to align with elements in the global intermediary settings, with their guidelines and their agendas and their ways of evaluating you. And then it also matters for what type of a disease you are innovating, both in terms of the funding that is available in this space, but also the type of the technicalities of the specimens is very different to work with blood than with sputum, for instance, and also the kind of historical culture in these in the TB control community, for instance, very different than HIV. And your competitors, you're also trying to align what you're doing to the competitors. For instance, the gene expert in the TB space really has set a very high bar for the followers to reach, because it is such an accurate test. And it also has set this price point of $10 per test, which is very difficult to achieve. And some of the developers I talk to, they say, well, this $10 per test only happened because there was this enormous buy down of many, many millions. And this buy down will likely not happen again. So it puts them at a disadvantage in reaching that bar. So developers aim to know and align elements to more settings than the intended use, but across these 5 settings that I just outlined. And what I was trying to show here is that there are a lot of different options that developers have. And these decisions often involve trade-offs. Should I now invest the next 3 months on further developing this plastic component, or should I rather work on trying to get my turnaround time to 20 minutes instead of 40 minutes? What really matters here? And there are so many different options, and they might not be aware of all the elements that matter, not necessarily that they're linking them. But the point is, people have to continuously make a choice. And so the alignment patterns actually might look very different. So I guess the takeaway here is that getting to know the point of care really requires substantive and ongoing investment. Because the users of global health diagnostics vary, shift, and are hard to access. So you need to spend time, challenge these users, invest in relationships. And you need to know and be able to navigate many more settings than just the intended use. And the intended use is already complicated enough. So that really shows that needs assessment is then essentially a core business of innovating. It needs to be done continuously through all phases, and it's not necessarily something that you do once or twice before you start your R&D, as it is often done now. But also, I think what became clear in my data is that a certain amount of uncertainty will always remain, because that's just part of inventing and innovating. And particularly, I guess, in global health, because a lot of these elements that ensure usage at point of care are not necessarily under control of test developers. So one HIV test developer highlighted this way. He said there has to be good reason for people to use it, and you have to get rid of all these things that are standing in the way between the technology you've developed and the use of it. And most of these things are completely not under your control because they're influenced by all kinds of other things, budgetary constraints and policies. And then, of course, this kind of alignment work that these developers are busy with, it doesn't stop once you're putting these devices into clinics. What happens then is that the implementers are taking over, in a way, the role of the developer. They are now busy trying to align these devices to their local setting. And then in a way, the alignment situation multiplies because you have many hundreds of clinics. And then as they do so, these implementers or end users, they might bring forward again other priorities. So for instance, they might expand the turnaround times because of the way, because they rather batch analysis cycles. They might complicate sample processing again because they prefer taking venous blood instead of finger pricks because they already, they need to use blood for other tests as well. They might avoid the connectivity that is inbuilt in these devices because of fear of viruses or Trojans. And actually, some of them might prefer stability over rapidity of results so that you can read a result over 2 hours of a device. And what's also clear, I think, in this implementation phase is that as these, some of the alignment to elements only happens after implementation. So linkages to care, for instance, and that often requires human resources. And it's very nicely illustrated here by this example of a TB officer who had a gene expert at his site, but no isolation ward, which is required according to the guidelines to manage and treat MDR-TB patients. So what he managed to do is he had a dialogue, as he says, and negotiated with a nearby medical college to take over patients diagnosed at his site for free, essentially. He would provide the medicines, but they could use the ward and would be cared for free. And otherwise, the test would have become sort of useless at his site because he had no way of treating these patients. But it required creativity. It required of a district TB officer to go beyond, his typical role and negotiation skills to do so. And I think that is why it's so important to link our efforts of innovating technologies to funding and attention for system strengthening as well. Because otherwise, however much work we do in getting to know the users, this alignment work will always continue in the implementation phase as well. So it needs attention and funding as well. So to conclude, I think what I was trying to argue is, or show at least with the second example, is that when we are developing and implementing a diagnostic for global health, we are not designing an artifact, but a usage, and that requires continuous needs assessment, and also more settings matter than just the setting of intended use in aligning that. But I think also what became clear is that developing a point of care diagnostic is a social process. So this mutual interaction between society and technology shines through as well. And I think I would end with a kind of an argument that we really need to make use of social science insights and research to document and analyze processes around designing, using, and implementing global health technologies much more. Because it will allow us some critical self-reflection about the innovation processes. That's it.
Thank you, Nora. That was really a wonderful introduction, and I think you've made a very persuasive argument I see that David Lessard has a comment in the chat. I'm going to come back to that in a moment, but I'm going to take the opportunity because, our setting and our audience is very much like most medical settings where 80 to 90% are very qualitative of our researchers are quantitative in nature, and a handful are qualitative. So we have trainees that are on this session right now. Can you spell out a little bit in more detail for the trainees that, how is it that qualitative research begins to unpick many of these things? When you present the information that you do, in retrospect, it looks very clear and like something we should be able to anticipate in advance. And in fact, it's a very it's a quite a process to be able to actually get all of these pieces and put them together to tell the story that you're telling. So if you can just talk about those qualitative strategies and aspects that are so important and that add so much more to understanding implementation.
Yeah, so I think the premise is just a slightly different one, that you try to really not, sometimes people who do not know qualitative research well, they think it is asking people about opinions and their preferences. And that is maybe a small part of it. But I like to practice it differently. I like to always emphasize that qualitative research is just as much about how people act on certain things. So it's about how you perceive something, but then also how you act on it. And with what you do and how you act, you shape the world, right? You construct technologies and influence all these things. And so by researching what people actually do on a day-to-day basis, and then talking to them also about how and why they do it this way, you then start to see connections between different things, and also how you conceptualize things. And that requires, going in depth with a few participants rather than reaching hundreds and hundreds of participants. Although I also know some anthropologists who do hundreds and hundreds of interviews, but most often we don't have the funding to do this. But I think the ability of these qualitative instruments to probe. So you ask a question and you get an answer, and then you ask 3 more follow-up questions to really understand what this person is telling you, and then an entire story unfolds. I think that is what allows you to generate richness, as opposed to, say, a CAP survey, where you just ask, what do you know, and not necessarily why and how you go about your day. And then bringing it together. There's ways to do it. Yes. The analysis is difficult. So I also teach qualitative methods, also at the McGill Summer Institute. We have an entire course on this. So if anybody's interested, you can always join that. That also takes experience and a lot of thinking and writing, and until you get to a point where you see these connections. I don't know if that answered the question or what you were hoping me to say, but
I think it does, and it really speaks to the importance and the need to involve qualitative researchers who have the background and the experience to be able to do this in a very thoughtful way, because it's a very different approach than most of us with a quantitative background will think about when even just thinking about implementation per se.
And I think also you can really study technology also, and technology use, and I think that's maybe sometimes people would shy away from this, or they think it is more, it has to do with studying stigma or something like this, but
If we have time at the end, I'll come back to a story of research that I was involved in with the U.S. government, where literally hundreds of millions of dollars were being spent on something that the users had no interest in. But I want to come to the comment of David Lessard. And David, if you're comfortable, why don't you turn on your mic and you can have the discussion of the points you've raised.
Seem to see the chat.
Well, you want me to ask a question? Well, as you see in the question, I'm obviously somebody from a social science department, trained in anthropology. I just wanted to know, you've spoken well about how qualitative studies can be used, to increase the uptake of technology or to make better use of them or more adapted, more tailored, etc. However, this is not exactly necessarily what we're going to learn in the social science department in many universities, especially in North America, where as I mentioned in my comment, they're taking maybe another tangent. We learn about critical theory, postmodernism, postcolonialism, feminism, Marxism. So we feel like we could provide some other analysis than just greater uptake of technologies. So it may create a clash, especially in multidisciplinary team. So I just wanted to have your perspective on this, or from your own experience. What do we have to leave behind? What do we have to bring? And how to accommodate, especially multidisciplinary teams?
Yeah, that's a great question. And, there are, of course, people who would think that this type of work is not pure enough. But I think you can do both. So I published some of this in very social science journals and some of it more in applied journals. And then you need to slightly alter your language. But I tend to, so I'm involved in projects where I'm asked to just find out what the users want, for instance. But you can still think about those things, or use this material to then also further kind of a social science discussion. And I think you can also bring in more critical, say, post-colonial or any of the other more critical concepts that you mentioned into these sort of studies, just with slightly different words. So I'm comfortable in multidisciplinary teams because I'm a mixed bag myself. So I have a very, very mixed social science background, and I didn't only study one field. And so that makes it maybe easier for me to do so, because you're used to switching languages or connecting things across fields. But yeah, I think there's a place for all of this, for very critical social scientists that just, some of them just want to stay in their own field, but we can then still, people like me can also use their work and then bring it into these type of more hybrid things as well.
Just could you quickly just have, I'm just curious about your input. What would be the interest of an institution like the Research Institute of the McGill University Health Center, that is very clinical, to publish things that would be more critical theory and more on the social science side?
Yeah, I think so. Are you mentioning you're concerned about the power differential here, that often the clinical knowledge gets a preference vis-a-vis that more critical knowledge? Yes, I would definitely agree with you. And it's maybe more uncomfortable knowledge at times that is created in the social sciences, that points to, colonial history that present themselves in the field of epidemiology, for instance. But I think if we want to move ahead and solve some of these global health challenges that we're seeing, we need to have more fruitful discussions across disciplines. Yes. So I'm a great proponent of this. I really enjoy working with epidemiologists and clinical scientists and lab technicians, also microbiologists.
And I think we all do better work when we involve colleagues from
and often people who are actually there's a lot of people that I've met in the field, but also in working in interdisciplinary teams, that have a very intuitive kind of understanding, say, of the basic principles of science and technology studies, which is also rather, creepy and not creepy, but unusual for some people to think about that technology has agency, right? But for a microbiologist, this makes sense, at least those that I've worked with.
We have a couple more comments or questions that I hope that we can fit in the last few minutes. Teresa and then Dan. I invite you to unmute.
You're muted.
Yeah, hi, sorry, I was just typing a note that I have to go to another event. But the thing is that I think your use of the term global health technologies, for me, who also works in the global health arena, specifically for intestinal parasites, and we have very particular biological specimens to deal with. The focus is on needs assessment and using more internet-based technologies to help with the diagnosis of some of those specimens that we receive. So the thing is, I do think it's very disease specific what you're talking about. I think that there are some general processes, but when it gets right down to it, it is very disease specific. And my only concern would be in the cost issue, the cost benefit ratio of these things. And when you said $10 a test, I just, I mean, we can't, in where I work, we can't talk about more than cents per specimen, cents, not dollars even. So I just can't right now reconcile developing these new technologies which cost so much, and reconciling that with global health, with vulnerable, what I consider to be vulnerable people, impoverished people. I mean, maybe you're talking about high income countries, I don't know. But if you're talking about vulnerable people and you use the TB example, no one can afford very expensive tests. So I'm just having difficulty trying to understand how this is done and how the medical system that exists today interfaces with these new technologies if they cost so much.
Yeah, so the Gene Expert is of course a good example. So there's different answers to the cost issue. Some people would say that, well, the real costs are probably even higher. And definitely we have ended up with a situation where there's differential access that's being created with the Gene Expert because it's not available for everybody. So because it is so costly, they had to develop eligibility criteria among patients. So only certain high-risk groups that are allowed access to these technologies, etc. And so your question is definitely a very valid one. Where in the system do we make decisions that we end up with technologies that in the end still cost $10 a test and are funded by donors who then do not fund, for instance, health system strengthening or rethinking sample transport, right? And some of this has to do, I think, with a persistence of this imaginary of silver bullets and the role of technology for human development, which persists in these circles. And then also very practical issues around this, like just how this technology came about. This was already an existing platform that was then adopted and et cetera, et cetera. So lots of work, of course, went into it. And it is a better test. So those patients who make it onto the machine definitely get a better diagnosis. So these, what a good test is actually very interesting to unpick. And I also wrote a paper about this idea of simplicity and what a simple and a good test actually is, and how different people, different value systems and practices of valuing and evaluating in global health also influence these processes.
Thank you.
And last question will go to Dan.
Thank you. Truly appreciated. Beautiful, beautiful study and a very difficult topic. I come to it also from the global health perspective, where I spent quite a few years in. And I guess hearing you struggling in this area of point of care tests, which is not what I'm from surgery, and I did a lot of global surgery. And I just felt a bit that the issue that what you're struggling with is what we struggled with so much in a very different thing, not technology based at all, which has to do with a disconnect a bit between the people that bring the innovation and bring the help and bring the assistance, and the people, of course, on the ground. And it really felt a bit like are we struggling? And this is beautiful. And what the previous comment was made earlier on was, are we struggling a little bit with issues which actually have to do with the need to decolonize what we're doing in these settings? Because I imagine, by definition, as much buy-in as you have locally, that buy-in is national type of buy-in. The country agrees, whatever, to have all these tests brought in. But as you say, the tests themselves are made by companies that have no clue about the realities on the ground. They're very distanced from them. But even those that bring them in, even sometimes the government institutions that bring these things into the little clinics, are not aware and don't really pay attention to this. And ultimately, the solution to what we did a lot in those settings, I'm wondering if it's the same sort of issue that we need to somehow, as you said in your thing, connect and be there, have the individuals that are involved at the lower level of the clinics and so forth actually be part of this process, as opposed to the recipients of these cute little $10 things that they have to use suddenly, and there's just no context for that or setting for that. Have you thought about, I mean, you already answered a bit that we should bring sociologists in and so forth, but I don't think we can separate, I don't think we need necessarily other scientists in this. I think it's just a reality of global health that we need to be aware that we're just bringing our own values, technology, whatever, into a context that's very different.
Yeah, no, I definitely agree with you. Yes, no, I totally agree. I don't know if I have so much to add to that, other than it's the thing is also that these diagnostic developers that I spoke with, they're sort of the underdogs in the diagnostic developer world. You know, if you want to make money, you develop flu and cancer and Alzheimer diagnostics. You don't try to develop a TB diagnostic. So they had, of course, also this idea of doing good, which comes with all these problems of the colonial past and all of these dynamics, the power dynamics and these issues with it. Yeah, so I absolutely agree with you. I don't really know what the answer is, but I think one way is at least to try to broaden the evidence base that people are using in making decisions, both in their design and also evaluation. And then another one is to argue for different practices altogether and being much more humble. Yeah.
I think from the discussion that you have generated, that you have clearly left us thinking about a lot of things and about much of the work that we all do as well. And it's a lovely introduction to you, Nora, for those of us who haven't met you before, and to get a sense of what might one learn much more about in the Summer Institute. So on behalf of CORE, on behalf of Dr. Pai, who arranged for you to be here today, I want to thank you very much for spending some time with us, and thank you everyone for making the accommodation to be able to come to the session at noon today.
Yeah, thank you so much. I also really liked the discussion, and I don't have all the answers either, so I'm also just continuously grappling with these things, and I think we're all never quite satisfied with it. Yeah, but that was really fruitful. Thank you so much.